Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. We'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor in the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. First, Dr. Jennifer Nuzzo, who is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give an update about trends that we're seeing in the COVID-19 data. Then we'll hear from Dr. Brian Garibaldi. He's the director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. Brian will give an update about the treatment of COVID patients. I'm now going to turn to each of our speakers for a brief overview. Jennifer, first to you. It feels like people are starting to exhale in the United States with the apparent decline of the Delta surge and the availability of vaccines for children ages 5 to 11. But based on the global situation, does that sense of optimism in the US make sense?
Thanks, Lainie. First of all, please don't exhale. No. So yeah, we are in a bit of an interesting situation where while the previous weeks we had seen continued declines in cases in the US, this week compared to last week, the cases have pretty much stalled. That's worrisome for two reasons. One is because we like to see the declines continue, but also because where we're stalling is at a level of weekly case numbers that is still well above what we saw at the lower periods at the end of June and early July. So we seem to be stalling out, plateauing at a fairly high case level. And as we're entering into the winter months where people are likely going to retreat indoors, probably do more interacting with others indoors, and likely traveling for the holidays, switching up their social networks, that just creates more opportunities for the virus to continue to spread. In terms of what we're seeing this week, about 22 states saw case increases, and 14 of these are in the Midwest and Western states. And so that's really where we're seeing the increases now, although we're also seeing increases in the Northeast. There are a number of states where these increases have persisted for 2 or more weeks. And again, that's usually the metric that we look for to say a trend is happening. So there are some early signs that we're headed in the wrong direction. So far, we haven't seen this stalling really translate into increased hospitalizations or deaths, but those are lagging indicators, and we wouldn't expect to see those for a number of weeks. So it's really urgent that we do more to address the stalling. Key, again, will be to continue to increase immunity in the population through vaccination. Unfortunately, if you look at the data in terms of the progress that we're making on vaccinations, we seem to be doing a lot more third doses than we're doing first and second doses, and there's still a long ways to go. The United States as a whole has not achieved as high of a level of vaccination coverage as a number of other countries, and that's really going to put us in a much more vulnerable situation. So in the United States, I would say, that optimism, I think, has to be tempered a bit, and particularly tempered when we look at what's happening globally. Globally, we're not just seeing a stalling of the cases. We had been previously, like in the US, seeing a decline in cases, but now we are not only seeing a stalling, we're actually seeing an increase in the number of cases being reported across the globe. Particularly worrying are massive case surges in Eastern Europe. But there are a number of countries in Africa that are also experiencing large case increases. Again, emphasizing the fact that this global pandemic is very much not over, and that we must make more progress in increasing vaccine uptake, not just here in the United States, but globally, because again, what happens elsewhere eventually could come here, particularly continue to be worrying about the emergence of new variants. But efforts to improve access to vaccines have also largely stalled, or we just just aren't seeing nearly as much progress as we need to. So, I would like to have a slightly more optimistic tone this week, but unfortunately, there are some worrying signs in the data.
Thanks, Jennifer, for both a candid and sobering response to my question. Before I turn to Brian, I want to remind our audience, please do submit questions for our panelists today in the box that you see at the bottom of your screen. So, Brian, I was hoping you could tell us what you're seeing in the hospital now in terms of both COVID and flu, and then speak as a clinician, what is the best advice that you're giving to individuals and families right now for staying safe as they look ahead to the holidays, which are just a few weeks away?
So right now, we're really not seeing much in the way of flu activity in the state of Maryland, and we're still very, very early on in what we would expect to be the beginnings of a normal flu season. COVID hospitalizations have continued to fall in Maryland. We're now down to about a little less than 600 hospitalized patients from a peak of about 1,000 a month ago. So we haven't really seen an uptick yet in cases in Maryland or in hospitalizations that Jennifer, I think, is appropriately concerned about. And we still continue to see predominantly among the patients who are coming to the ICU, they're either unvaccinated individuals or folks who are on immunosuppression and have not mounted a response to the vaccine. I think there is reassuring data from the CDC and large influenza-like illness cohorts that continue to come out showing that the risk of hospitalization and severe disease is much higher in unvaccinated individuals. So the vaccines are still holding against Delta. So I think it's really critical, as we still haven't really crossed that threshold of even 60% of people in the US being vaccinated. We still need to push very hard to get people who have not yet gotten their first series of vaccines to get vaccinated. And that includes children. I think many people are very excited about the fact that children ages 5 to 11 are now eligible to get vaccinated, but I think it remains to be seen what that enthusiasm is going to be for vaccinating kids. We know that right now kids are at very high risk of getting COVID and spreading it amongst themselves, but also to potentially at-risk family members. So I think it's really important for people to consider whether or not they want to get their 5 to 11-year-olds vaccinated. We know that this vaccine is safe. We know that it's effective. But until we have a wider percentage of children vaccinated, I think we still need to push really hard on things that we know are effective at mitigating spread, including mask mandates, particularly in schools where unvaccinated people are congregating together. I think the data is very clear that in schools that have masks, transmission is much lower than in school systems that have not implemented masks. We don't really know what to expect about what's going to happen with the flu season. So last year we saw almost no flu cases throughout the United States, and a lot of that was related to the mitigation measures we have in place for COVID are effective against the flu. There was also not a lot of travel, which is really how flu spreads. There has been some flu activity in the Southern Hemisphere. We have yet to see a case in our hospital here in Baltimore. And so it's not clear what's going to happen as people start going indoors. There's still going to be COVID circulating. There still likely is going to be some uptick in flu activity. So it remains to be seen what that co-infection might do to people, particularly those who are immunosuppressed. So what I've been telling folks, particularly patients who are at risk for severe disease from COVID, but also from the flu, get your flu shot, get your COVID shot. We know that it's safe to get both together. If you want to do one-stop shopping, if you haven't gotten your COVID vaccine yet, you can get your COVID vaccine at the same time that you get your flu vaccine. I think it's important to get both this year. Even though we haven't seen a lot of flu, we actually have seen a lot of RSV infection, particularly in outpatients in kids. But we have seen some adults who have been coming in and getting hospitalized with RSV, and this is a little bit early in the season. But the RSV cycle has been sort of thrown for a loop because of all the mitigation measures for COVID. And as people start interacting more as they've been vaccinated from COVID, we have seen an uncharacteristically high uptick in RSV in the previous months, but we're starting to see that translate to outpatient infections in kids, but some hospitalizations as well. And I think that's something for people to consider as they do go inside and as they're considering, when would it be appropriate to mix with larger groups indoors. I still wear a mask when I go inside anywhere. I think it's probably reasonable for people to continue to do that until we have a wider uptake of COVID shots. But also, there are seasonal viruses that are circulating. While RSV typically doesn't impact adults with healthy immune systems, it can really impact those who are immunocompromised, and certainly can impact kids, particularly younger kids. So I think it's still appropriate to continue to wear masks indoors to be really diligent about hand hygiene and to really consider getting vaccinated if you're eligible and haven't been so, including those 5 to 11-year-olds. A couple exciting new developments in COVID therapies. Pfizer just released by press release some results from a trial of their oral antiviral drug, where they showed in about 400 people who got the drug within 3 days of testing positive for COVID, they reduced the risk of hospitalization and death by almost 90%. And then in patients who got the drug within 5 days, it also was effective at reducing hospitalization and death, but it certainly seemed to be more effective earlier. This is just by press release. We haven't seen the primary data yet. We're hoping to get that soon, but I would expect that Pfizer is going to be looking to apply for an emergency use authorization soon based on the strength of the data they released today. And then later this month, the FDA is going to be considering the emergency use authorization for Merck and Ridgeback's oral antiviral molnupiravir, which also was shown to be effective in a similar size trial at reducing hospitalization and death. So I think, on the horizon, we're hopefully going to have some additional therapies that we can use to treat individuals who do become infected with COVID, particularly if we can get them tested early, recognize the disease, and be able to treat it. So I think as we get into flu season, the other advice that I've been telling people is, if you have what seems to be a cold, don't just assume it's your normal winter cold. You should still get tested for COVID because particularly in high-risk individuals, we have treatments that can reduce your risk of getting severe disease. So when you have symptoms of an upper respiratory infection, you should get tested.
Thanks so much, Brian. And before we turn to Q&A, and I do see questions coming in quickly, I want to remind our audience that we have a weekly newsletter that you can subscribe to from the Johns Hopkins Coronavirus Resource Center. It is called The Week in COVID-19, and it is a great way to get the latest analysis from our experts about the virus itself, variants, and other critical trends, delivered to your inbox on Mondays. And now I'm going to move over to Q&A. So, Brian, I'm going to pick up on a thread that you raised, one that is very close to my heart and Jennifer's, I know, because we are both the parents of children who are between age 5 and 11. So the exciting news that not just the news, but the actual availability of vaccines for this age group. What would you say as a clinician to parents who are hesitant or who want to wait a little bit as opposed to being among the first to get their children vaccinated?
Sure. So obviously this is an important discussion for folks who have young children. The FDA asked for additional data to make sure that as best we can, as quickly as we could, understand what the safety and potential benefits of the vaccine are for kids. They doubled basically the size of the trials that they were looking at in 5 to 11-year-olds. And by and large, this vaccine continues to be very safe, and it also continues to be very effective at preventing severe disease and death and even symptomatic disease in kids. So I think the risk benefit is definitely there to prevent disease, to prevent kids from getting sick, to prevent them from spreading it to other potential at-risk people in the community. The risk benefit is very much in favor of getting as many people, including kids 5 to 11, vaccinated as quickly as we can. There's always this concern, as we saw in younger, particularly men or adolescents, there is a slightly increased risk of an inflammation of the heart called myocarditis or pericarditis. The risk of that actually happening from a COVID infection is far greater than it happening from a vaccine. And while we continue to have very high levels of community transmission of COVID, kids are much more likely to get severely ill from COVID than they are to have even a mild side effect from the vaccine. And so I think the risk benefit far favors getting vaccinated for kids 5 to 11. I think the sooner we do that, the better off we're going to be in preventing what we hope is not going to happen, but a winter surge as we all go inside and start congregating more.
Thanks, Brian. Jennifer, several questions coming in about testing, especially as we see this proliferation of at-home testing kits. So what's your advice? How do you square it if you get a positive result on a rapid and a negative on a PCR? What's your advice?
Yeah. So, I really think that you should have a conversation with your clinician when this happens. It's hard to just parse based on that information. But until you are told otherwise, I would assume that a positive is a positive, in part because you don't want to inadvertently spread it to others during that time. Your clinician may want to get another test. We have heard about people testing positive on rapid tests, and it's not an accurate result, but it's hard to just tell based on that information in all circumstances. So it really would be something to speak to a clinician about. This is the challenge with home testing, is that when you take what is ultimately a diagnosis out of the medical environment, you're not benefiting from the clinical expertise and the interpretation that would usually go into telling somebody that they do or do not have a particular infection. So my best advice would be assume it is positive until a medical professional tells you otherwise and clears you to go about your daily life.
Thanks, Jennifer. Another question for you about a topic that we haven't talked about in a little while on this briefing, which is herd immunity. So what are your current thoughts about herd immunity relative to COVID? And I guess let's just stick to the US since it's such a big topic.
Sure. So I don't really like to talk about herd immunity in the context of COVID.
I know. I apologize.
I know. But I do think that everybody is wondering about it. Herd immunity is really a concept that helps us sort of understand how much of a population we would have to vaccinate, not just needing to vaccinate anybody, but what the collective impact of vaccination would be, such that we would expect to see, a decline in the incidence of cases. I think in the context of COVID, what we're really talking about is how much immunity does there have to be in the population such that the level of COVID that occurs is manageable, not an emergency situation. And that's really going to be a product of two things. It's a sum of two things. It's going to be the people who got vaccinated and the level of protection that vaccines offer, as well as the people who have already had COVID. Now, that's a little bit trickier because we know that not all infections produce the same level of immunity. And so that is why you're still encouraged to get vaccinated, even if you have had COVID. But it is clear that having COVID confers some level of immunity in the population. And so places that have been hard hit through infection will have a higher level of immunity than places that have been spared and have not yet made progress in vaccination. So I think what people are basically wondering when they're asking this question is, when is it all over? And I will tell you that we still have to do a lot more vaccinations. I think being able to protect kids through vaccines is also helpful, although CDC's modeling suggests it will probably have a tinier impact than certainly redoubling our efforts to vaccinate adults. So we have to make sure we do that. And I continue to be alarmed by the fact that we're probably making more progress on third doses than we are on first and second doses. I looked at the vaccination statistics today, and the US still very much lags other countries in terms of being fully vaccinated, which at this point we're talking about, 2 doses for the mRNA vaccines and 1 dose for J&J. So we have a lot more work to do. And really that's the question is, what can we do to get to a point where we have more people protected through vaccination?
Thanks, Jennifer. This next question, Brian, I'm going to start with you, but Jennifer, you may want to weigh in as well. Brian, I know you are a big fan of masks. I am never more than arm's length away from one myself. So the question, Jennifer? Okay. Show off. So the question is, come January, are we heading towards a point where we go back to being a maskless society? How do you think about that? And like I said, Brian, I suspect both of you will want to weigh in, but why don't you start?
Well, I think there's a lot of uncertainty about what's going to happen over the next couple of months, right? And I think Jennifer correctly raised some concerns about the plateauing of the decline in cases that we had been hopeful about over the previous couple of weeks. And we're heading into a point where it's colder in a lot of the country right now, and people are going to be spending more time indoors. I think it just remains to be seen what happens over the next couple of months. I do think we need to be starting to have discussions about being flexible with our masking policy. And it's not an absolute, right? I mean, there are going to be times where it makes sense for us to be masked up indoors, but I would love us to be having a discussion. We've developed so much more capacity in this country to test and do surveillance for not just COVID, but for other influenza-like illnesses. And I really wish we could have a discussion to talk about, hey, we know in this particular geographic area, there's high circulating levels of influenza or RSV or COVID. It might be a good idea right now for everyone to consider masking up if you're in a large indoor gathering, right? That's the kind of discussion that we should be having. But unfortunately, things have become so politicized that we can't even talk about, following the data to say, hey, when would it potentially be safe to say we shouldn't mask up? I think right now there's a lot of COVID in the community still. If you're going to be indoors with people from outside your household, you should really strongly consider wearing a mask, even if you're vaccinated. That's been my approach. That's been our family's approach. And I think that continues to be the way I would think about it until we're at much, much lower levels of community transmission.
Thanks, Brian. Jennifer, want to weigh in on this one too?
Yeah, I mean, I've been a proponent of having a conversation about what the exit ramps for masking are, in part just because I think everybody has a different level of acceptability with masks and a different level of risk tolerance. And so the question really is about how long is it required versus, obviously everybody is perfectly welcome to wear masks for as long as they wish, but for how long is it required? That said, when you talk about exit ramps, we're talking about what data, what are the epidemiologic and operational conditions that would allow people to no longer be required to wear masks in a way that is considered safe enough. It's not setting a date and then just, sticking to that date regardless of what the circumstances are. But it's trying to understand at what point would we as society feel comfortable no longer requiring people to wear masks, but of course allowing them to continue to wear it if they so wish.
Thanks, Jennifer. And picking up on what you just raised about the data and the epidemiology, we have a question about reliability of data, cases, deaths, vaccinations that are coming in from other parts of the world. So what are your thoughts about data quality and potentially missing data globally?
Yeah, so my biggest worry in terms of the global data is that being able to diagnose an infection, being able to determine COVID as a cause of death requires a capacity that not all countries have. So that is the biggest problem, is that places like the United States, even though we have absolutely been plagued by testing woes and are still not doing nearly enough testing, are in fact doing a lot more testing than a number of other countries. We are not the best. There are many countries that really blow the United States out of the water in terms of the level of testing that they do. But when you compare the amount of testing that happens in these countries to other places where, people are not even being diagnosed when they are very clinically ill and die, and other countries that are largely only testing travelers because travelers pay for testing. When you have circumstances like that, you can't assume that the reported cases or even the reported COVID deaths are even close to an approximation of the number that are actually occurring. They're underreported everywhere, but in places where the testing capacity is severely constrained, they're very much underreported. In fact, WHO had put out a notice saying that in the Afro region, they estimate that about 6 out of every 7 infections are not being diagnosed. So that is a considerable undercount. So that is my biggest concern. Of course, different countries have different definitions for cases, different definitions for what they're counting a COVID case versus a COVID death, different types of testing used and different amounts of testing. So all of that adds variability. I wish we had greater global standards, but really I think the biggest driver in the uncertainty in the data is one of lack of capacity. And the bottom line is what is reported officially is likely a vast undercount.
Thanks, Jennifer. Brian, question for you about monoclonal antibodies, about availability and then awareness among the public.
Well, I think we've seen an increase in the use of these drugs, particularly during this latest surge. The U.S. has the HHS, which distributes the monoclonal antibodies, has a way of monitoring caseloads and then making certain numbers of doses available to states by, I can't remember what day of the week they do, but they basically say these are the doses that you would be eligible for, and then the state reports how many they'd like to get, and then based on how many numbers they have and how much they use, that opens up the distribution of those doses to potentially other states. So I think we're doing better by and large at getting the doses to people who need it. But we're still not reaching everybody and not I think one of the biggest challenges is not just can you get enough doses to the right place, but do you have enough healthcare providers to actually administer those doses, which is why there's so much excitement about oral therapies, because these monoclonal antibodies require, in most cases, someone to place an IV and to do the infusion, although we can give them subcutaneously, but you still have to monitor someone for a certain period of time afterwards to make sure that they tolerate it well and don't have a reaction. And we're so limited right now in many industries, but particularly in healthcare and frontline healthcare providers to do that it's been a big challenge to balance testing needs, vaccinations, and delivering monoclonal antibodies to those who might benefit. So that continues to be a challenge moving forward.
Thanks, Brian. And since we're just about at 12:30, you will have the last word for this briefing. I'd like to thank Jennifer Nuzzo and Brian Garibaldi for joining me today, and give a big thank you to everyone who joined us, and especially to those who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. And as a reminder, we do offer these 30-minute briefings regularly on Fridays at 12 p.m. Next Friday at noon, we're going to have the third expert forum within our pandemic data initiative. And that session will include a conversation with journalists and researchers from Johns Hopkins, from the New York Times, and from the Atlantic's COVID tracking project. These are all folks that have been on the front lines of collecting, visualizing, and interpreting data throughout the COVID-19 pandemic. I will look forward to seeing you soon. Until then, thanks and stay safe.